So, any questions before we get started here? You got a question about this? Not clear? Okay. This is about 40 minutes about the non-arteritic form of ischemic optic neuropathy. And I'm going to try and give you some practical information about this, and then a little bit of a off-topic, related topic at the end, talking about a spectrum of optic disc ischemia that includes an AION. So, again, the general definition for anterior ischemic optic neuropathy: males equal female, usually over the age of 50. It's a painless loss of vision. It's always a painless loss of visual field. It's not always a painless loss of acuity. Depends on where the field is involved. If it involves a fixation point, then acuity goes down, but you might have normal acuity and have NAION. If there's asymmetry, there's a relative afferent pupillary defect present. And essentially, there's always optic disc edema in this anterior form of ischemic optic neuropathy, and often flame hemorrhages and other features that I'm going to show you. So question number one is, when you see this scenario, is it temporal arteritis? And you just heard several minutes about giant cell arteritis, I think. So this is the case where it's not giant cell arteritis. That's about 90 to 95% of ischemic optic neuropathy, and the mean age is lower. So it's roughly the age of 60 or so is the average. Usually no systemic symptoms, and the sedimentation rate is in the lower range. The visual loss is less severe than giant cell arteritis. And there's a static form, which is roughly 75%, depending on who you read, in which there's a loss of vision, and it basically stays the same, and there may be a mild amount of recovery over the next several months. And there is a progressive form, the minority of these cases, in which there's a loss of vision, and then there's another loss of vision. There may be a stepwise decrease for a month or two, or even a progressive loss for a month or two, and then it levels off. The fundus in these cases, typically the amount of edema is relatively mild to moderate. It may be segmental, and if it's this kind of a picture in which there's more edema here than here, this sort of indicates that there are actually possibly two events in this case. This one was older, and this is a more recent event. But anytime you have that segmental edema of the disc, most often you're talking about ischemic optic neuropathy. And usually in the non-arteritic form, as opposed to the arteritic form, the non-arteritic form is usually hyperemic swelling. It's not chalky white pale swelling. Some of the textbooks talk about pale swelling for ischemic optic neuropathy, but for the most part, the non-arteritic form is hyperemic when it starts. And then if you catch it later on, a few weeks into it, the atrophy is starting to come in while the edema is still there, and it sort of looks like pale edema, but it's not the chalky white edema that you see with giant cell arteritis. And occasionally, the disc is markedly swollen and has this telangiectatic vascular dilated net on the surface, even some swelling of the disc substance itself. It can even look like a vascular tumor of the disc. That all goes away over the usual 4 to 8 weeks evolution of ischemic optic neuropathy. So it can look like any of those things. Dr. Harden talked a little bit about peripapillary arteriolar narrowing earlier. That happens in most optic nerve damaged cases. So if you have an atrophic nerve, a lot of those cases are going to have peripapillary arteriolar narrowing, like this, where the arrow is. You've got to be a little careful when you're interpreting this sign to make sure it's not just obscured by the edema. But if you can see that arteriole and it's narrow, and then it opens up as it goes away from the disc, to me that's one of the markers for ischemic swelling rather than papilledema swelling, for example. It won't usually do that for papilledema. And in the non-arteritic form, the fellow eye has a crowded disc, and the cup to disc ratio is small. The actual disc diameter may be a little bit small as well. Perimetry for NAION, most of the time it's altitudinal, but you can get almost any kind of optic nerve visual field related defect in ischemic optic neuropathy. So arcuate defects, generalized depressions, even cecocentral scotomas occasionally with NAION. But the most common, in the non-arteritic form particularly, is altitudinal and inferior. The clinical course for this is generally stable. As I said, most of the cases, you have some loss of vision. They don't really change much after the loss has bottomed out. But about a little over 40% will get some improvement, 3 lines or better in about 40% in the AION, which was our trial of optic nerve sheath decompression for ischemic optic neuropathy. So this was something that people didn't really realize before the trial was done, is that they do improve. 3 lines may or may not be a big improvement for that patient, but 40% of them are going to have that. And it's important to know this figure when you start looking at all the possible treatments that are out there, because there is this spontaneous improvement rate. And a lot of the treatments that have been done in small pilot studies, the treatment effect is very similar to this. Recurrence is unusual in non-arteritic AION, but it does occur in the same eye, a second event, after that first 2 or 3 months. So maybe 6 months later or a year later, they may have another event happen, but it's unusual. And what should happen with non-arteritic AION is that the disc edema goes away in 4 to 8 weeks, and it may be segmental like this. And when I see a disc like this, it's atrophic on the top, and the bottom probably has a little damage as well, but it's not nearly as much, and there's a horizontal line across it like that, there's not much else that does that other than ischemia of the disc. If you had a hemiretinal artery occlusion, you might get that, but those are really rare. And usually if I see this in the correct disc configuration, one of these small discs with no cup, that's a marker that that's been AION in the past. The slide is to remind me that if the edema doesn't go away in 4 to 8 weeks, you need to look for a different cause. So this should go out. If it doesn't, you need to follow the patient. And if you follow them and at 2 months or at 3 months, they've still got disc edema there, it's something else. So it's chronic inflammation, it's infiltration of the nerve, optic nerve sheath, meningioma, for example, or something else is going on there. So that follow-up is really critical in managing NAION. So a question that has been coming up in the past few years is it really ischemic? What evidence do we have that it's ischemic? So the hypothesis for arterial insufficiency is that it's a vasculopathy of the optic nerve head blood supply. There's impaired perfusion secondary to progressive lipohyalinosis or some other process of the microcirculation. The circulation that's derived from the short posterior ciliary arteries, and in the presence of a small crowded nerve head, which is predisposed to having this vicious cycle. You get some swelling, it'll compress the vasculature, which will produce more ischemia, produces more swelling, and you get this cascade effect, and it results in an infarct in the nerve. That's the arterial insufficiency hypothesis. There's also a venous insufficiency hypothesis in that, and it states, this has been proposed by Len Levine and Helen Danish-Meyer and their group, is that it's not primarily an arterial disease, it's a venous disease. Venous congestion starts things off, you get edema, you get secondary compression, and you get ischemia secondary to that, with the compartment syndrome again. And you may have secondary vasoconstriction along with that as a component. And that theory kind of might help explain discs that get swollen and have normal function, and over weeks they eventually develop ischemic optic neuropathy rather than have the loss of vision at the start. So that makes some sense to me. Both of them actually make some sense to me. There's one that doesn't make much sense to me, and this has been proposed in the last few years. And the proposal is, from Dr. Parsa primarily, that it's not an ischemic disease at all, not venous, not arterial. It's traction related to vitreopapillary traction, and the optic neuropathy is caused by vitreous traction on the optic nerve head with a shear force of injury of the axons. He kind of puts this forward as one end of the spectrum of the vitreopapillary syndrome, which is a little bit different than that. But the hypothesis is it's not an ischemic event at all, it's something else. That ignores a lot of data out there. I'm going to show you some of the data supporting ischemia as the cause. But it's out there. I'm not a believer in it. So for arteritic AION, I'm sure Dr. Carden showed you this, but we have good evidence that in arteritic ischemic optic neuropathy, there is blockage of the short posterior ciliary arteries due to the inflammation and the thrombosis, and it results in an infarct in the optic nerve head, and there's a lot of data supporting that. So that's a circulatory problem for sure. Why do we call NAION ischemic? Well, it has an acute subacute onset. It has vasculopathic risk factors. It's a discrete event with resolution over weeks. It's stable after that. And a lot of that is very similar to giant cell arteritis and AION, which is a proven infarction. There are very few histopathologic documentations of optic disc infarcts in clinical NAION. There are some series looking at the infarcts histopathologically in microscopic diagnosis of ischemia, but without the correlating clinical scenario with it. But there's no histopathologic documentation of the location of the vasculopathy in non-arteritic ischemic optic neuropathy. So we're calling it an ischemic disease, but what evidence do we have? Well, one piece of evidence that I think is pretty reliable, although I'm looking at this again recently and there are parts of it that I still don't understand. But if you look at a normal fluorescein angiography of the disc, and you start looking at very early pictures like this, you need to see this as things are filling. The normal disc fills with the choroid, and they both fill segmentally, but they're both generally done within 5 seconds or so. And then the central artery circulation fills in, and there's a superficial net on the disc that lights up at that point. So that's normal. In arteritic AION, and I'm sure you talked about that a little bit earlier as well, this is sort of the chalky white disc of arteritic AION. Poor filling of the nerve, also poor filling of the choroid, suggesting that this is a short posterior ciliary artery and a really beautiful electron microscopic cast from the 90s, suggesting that here's the pathology, which is also documented on histopathology studies. And fluorescein angiography with this marked choroidal delay is pretty typical for AION, but the disc is filling poorly also. So that's suggesting that at least there's delayed filling within that nerve. In non-arteritic AION, there's also poor filling of the nerve. This is 16 seconds into an NAION. Central retinal artery is filled, choroid is filled, there's basically nothing on the disc there. And that takes another 20 seconds or so in order to get that, suggesting that NAION is not a large short posterior ciliary artery blockage, which would knock out the choroid as well, but it's distal to that somewhere in the microcirculation of the disc. Non-ischemic disc edema, papilledema, and others, fills early. There's no delay in the filling of the nerve. Actually, in most cases, it fills earlier. There's a big flush of fluorescein in there, and this is 12 seconds into the fluorescein where the disc is filled quite easily in those situations. So you can kind of tell the difference between non-ischemic swelling and ischemic swelling of either type. We've been looking a little bit, this is just some preliminary data, just looking at high resolution swept source OCT angiography of the parapapillary retina and of the disc itself. There are limitations as to what you can get out of this, but we've been doing some perfusion density calculations. This is a sample, I wouldn't quote this to anybody, but as we looked at these, the deep parapapillary circulation seems to be a bit diminished in NAION compared with papilledema. It's a little difficult to compare these to normals because of the cup that's here, and depending on where your slab is, you may not be hitting the vasculature essentially, but these two we compared about the same amount of edema and found a significant difference, not in the disc here. This is in the parapapillary retina. And this is the disc, which is sort of a similar kind of thing in this swollen region. Decreased perfusion density, which is sort of the volume of the vessels within the volume of the area that you're looking at. And it may turn out to be something, this is really preliminary data, but we're investigating whether you can tell ischemic from non-ischemic edema just by doing this non-invasive swept source OCTA. But it looks like it might be supportive of decreased circulation in those areas. So let's take a case. It's a non-arteritic AION case. 65-year-old guy, blurred inferior visual field while watching TV. He has no pain, no systemic symptoms. He has a relative afferent pupillary defect on the right side. He has a little bit of disc edema, and he has an inferior arcuate visual field defect. So you ask him about his history. Here's a typical history for an NAION patient. Do you have hypertension? No, I don't have hypertension. I have to take medication for it. Do you have hyperlipidemia? Is your cholesterol high? No, it's fine. Take medication for it. Are you a smoker? No, I don't smoke except after meals. So it's a typical sort of vascular path that comes in with NAION. So what do you do? Do you need to do carotid Dopplers? Should you do an MR angiogram? I mean, you're thinking this is a vascular disease. You need to look at those. There are some good studies quite a while back looking at whether carotid stenosis was significantly linked with NAION patients. Small studies, but similar results in both, in that they did not find a significant link between carotid disease and NAION, even though you might think there might be a good link. There wasn't much of a link, suggesting that this is a small vessel disease rather than a large vessel disease. And the corollary would be we don't usually do an MR angiography for this as well. Do you need to do an MRI? Usually no. It's a clinical diagnosis. Do you need to do a visual evoked potential? Usually no. What about doing an OCT for this? I showed you some OCTA there. You might. I'll show you this in a second. And of course, you probably are going to do the CBC and C-reactive protein, etc. Here's why you might do an OCT. You got the clinical diagnosis there, but if you do the OCT and you have a cross-section going through the macular region and you can see fluid under there, which occurs, it's a relatively minority of the patients, but if that's there, just from the swelling, your prognosis for recovery may be better, and you may be able to tell those patients that their recovery chances are better. So that may be helpful in evaluating NAION patients and providing some prognostic information. Do you put them in a hyperbaric oxygen chamber? Do you do optic nerve sheath decompression? Do you cut the vitreopapillary adhesions? Do you inject something into the eye? So there's all kinds of things that are out there. I'm going to show you some other ones that are out there. Here's what I do if I have the patient with NAION. Number one, I make sure it's non-arteritic, and we talked a bit about this already. Evaluate what the risk factors are. Evaluating the risk factors is really important for these patients. You may be the first person that tells them they've got hypertension that's poorly controlled. They may not have known about it. You send them to the internist for that situation. You might save their life. I provide them with the prognostic information, what to expect. Everybody wants to know what to expect after they've had visual loss in one eye from NAION. I provide them some balanced counsel about all the things that are out there that are unproven to treat this disorder. And then I consider whether some prophylactic measure might be appropriate to reduce the risk of fellow eye involvement. So this we talked about already. The risk factors, there are more than this, but we think about these as kind of the major risk factors for NAION. Hypertension, diabetes, hyperlipidemia, smoking. There's variable information supporting those, but we look into those in general to assess for it. There are two others that I want to just bring up briefly. One is obstructive sleep apnea, and the other is the PDE5 inhibitors. So the sleep apnea syndrome is really well linked to cardiovascular disease. It's linked to the metabolic syndrome. It's linked even to having an elevated C-reactive protein and an inflammatory disease in addition to the other problems that happen with this. It's linked to hypertension. It's linked to cardiovascular disease, basically. So there has been increasing evidence that sleep apnea is a risk factor for NAION. Started around 2002. These are all sort of small series looking at the risk. So looking at patients with NAION and evaluating whether they had sleep apnea, either by sleep studies or doing questionnaires, some way of evaluating that. And the numbers are really striking. So 71% in this original paper from 2002, almost 90% in this paper. And this is our paper more recently at about 56% with versus controls, a significant difference between controls in this relatively small study. I remember when this came out, about 2002, this was presented at the American Academy of Ophthalmology, and I was the discussant for this paper, and I thought, this is nuts. I thought, impossible, right? I don't see 70% of my patients having sleep apnea. I thought about sleep apnea as a disease of the obese, and patients coming in obviously lethargic and clearly at risk for sleep apnea. It's not that way, and there's more and more evidence suggesting that this is a significant linkage. So we inquire about this. We don't send everybody for a sleep study, but we make an inquiry. If there's any suspicion, we do send them for that. And they should be treated. Now, whether the treatment reduces the risk for ischemic optic neuropathy is debatable, but treating sleep apnea is definitely beneficial for reducing the risk for other vascular problems. So we do evaluate that. I'm told that these are Viagra pills. I don't have any personal experience with this. I'm not sure if anybody in the audience can confirm what these are, but these are some sort of pill that seems to be linked. So there's evidence that the use of PDE5 inhibitors is a risk factor for the development of NAION. This sort of came on in the early 2000s, and then one of the larger studies was 2005, looking at new cases and old cases of NAION following the use of PDE5 inhibitors. They all had vasculopathic risk factors, they all had crowded nerves, and they all had events happen within the time window for the drug. Since that, there are actually more than 100 reported cases, and of course, all the cases that happen are not reported. It's plausible that that might have an effect. It's a vasodilator, nocturnal hypotension. If you exaggerate that, you may hypoperfuse the nerve head. Dilating within the optic nerve head may actually increase the compartment syndrome. If you're dilating the vessels within that crowded part of the nerve, maybe you're potentiating the ischemic event that happens in there. Local vasodilation within the nerve head also probably impairs autoregulation, which may be one of the causes for ischemic optic neuropathy. So many reasons why it makes sense that the drug might be related. I was the data safety chair for this. I'll put that to disclosure out there because I am biased to think that this is probably the best study looking at the link of NAION to all of the PDE5 inhibitors. This study actually was looking at all of the major ones, not just Viagra, although it was performed by Pfizer. Case crossover methodology. So bringing patients with NAION and then going back and looking at their exposure to the drug, comparing their risk during the window of exposure to a time window before that, so-called case crossover methodology that was approved by the FDA for the study. And it was a pharma-sponsored study. Everybody thought they're going to set it up to fail, and it won't show any link. But the study actually did show a link. It showed an increased risk, about a little over 2 times the risk during the 5 half-lives of whatever PDE5 drug you were using, compared with the prior time window in which you weren't exposed to the drug. That still is not very many cases. The estimated cases were about 3 per 100,000 per year, but there is that risk out there. There is another study that's a claims database study looking at, it's an epidemiologic study looking at prescription of the drug versus the development of NAION. Not whether you actually took the drug, not how much drug you took, but prescription of the drug. It did not find a significant benefit. As I said, I'm biased for the other study. I was a part of the safety committee for that, but that's kind of where I am with it. So what do? You have NAION, you evaluate the risk factors, you look into those things, you assess them for sleep apnea, you talk to them about PDE5 inhibitors. How do you treat them? This is a partial list of the things that have been tried. They're all over the place, including vasoconstrictors and vasodilators, both. Think about that for a minute. Lysis of vitreopapillary adhesions, transvitreal radial optic neurotomy, LDL apheresis, transcorneal electrical stimulation. There's a lot out there. So people asking about some of these, I like to provide them with some counsel about it so they don't get involved with some of that stuff. But there are some of the ones that are more commonly talked about. I want to just mention for a moment here, corticosteroids, intravitreal VEGF inhibitors, intravitreal steroids, intravitreal neuroprotectives, which is the latest thing that's going on for this disorder. So one of the big studies looking at oral corticosteroids for NAION was Dr. Hayre's study, published now, it's about 10 years ago. It's a large series of patients with non-arteritic AION versus controls, done over about 22 and a half decades or so, giving prednisone at 80 milligrams a day for 2 weeks and tapering over 2 months, beginning within a reasonable time window, several weeks after the onset of the NAION. And at 6 months, his results were that the visual acuity improved by that 3 lines in 70% versus about 40% of the control. So the control patients were about what you would expect for the natural history based on the other studies. Just in patients that are worse than 20/70, we'll look at it in a minute, and also some data that indicated that the visual fields improved as well. So and the study did show, as have some other studies, that steroids make the disc edema go away faster. There are problems with it, and it's a very controversial study, and I would have to say probably that the majority of the neuro-op community does not use oral steroids for this. There are some major exceptions to that, and there is some room for discussion about it. But if you want to counsel your patients about this, you should actually read the study and look at the way that the data was obtained and the way the data was analyzed. There are several issues. I don't want to go into the details of them. It was a voluntary group assignment, not a randomized clinical trial. That's not a major issue. The examiner in the study was non-masked. And I said before, the 2070 patients were the ones that were analyzed. So at the end of the study, there were only 70 eyes out of the study that were analyzed for final data, excluded more than they used, because the thought was that if your vision is better than 2070, you're in a group that doesn't have a lot of room for improvement. So there's some adjustment of the data on that, and there are some issues with that study. So if you're going to talk to patients about using oral corticosteroids, you should look at that. There's a funny interchange in the literature recently, 2013, where a group from Spain did a small study, a much smaller than the Hayres study, obviously, and tried to replicate the data. They got through 10 patients and they stopped because several of their patients had complications, more than you might expect actually from oral corticosteroids, but they stopped and said in those 10 patients, they didn't get a benefit from the steroids. Dr. Hayres wrote back, as he often does, and if you've read the literature of him, he writes frequently. He wrote back and said, your study has no merit, it's too small. They wrote back and said, we wanted to believe your study, we just couldn't get a benefit from it. It's a sort of classic interchange in the literature there. So there's also a newer study of oral corticosteroids. It just came out, it's not in my slides here. It also did not show a benefit of oral corticosteroids. There is also a study of intravenous corticosteroids for NAION that came out of Israel. And the bottom line for this one as well, retrospective review, not a prospective trial. But the end point of that was that the intravenous corticosteroids did not have a significant benefit. What about injecting into the eye? So intravitreal injections, the goal being to speed up the edema resolution. Just as the oral corticosteroids, the goal is to speed up the resolution of the edema, reduce that compartment syndrome, and hopefully have a better outcome. So the two main things that have been done in the past are VEGF inhibitors and intravitreal steroid. The intravitreal steroid, there were a few series, not much came out of that. I don't think people are still doing that. I want to just emphasize the issue of intravitreous VEGF inhibitors, because there's potential downside for doing this. There are a couple of trials that actually showed no benefit for the injection, but there are also some significant risks with doing intravitreal VEGF inhibitors for NAION. There are patients who had NAION, got an injection, and had another event of NAION right afterwards. There are patients with macular degeneration who had intravitreal VEGF inhibitors and developed NAION. So this has pretty much been abandoned, I think. So the intravitreal steroid or VEGF inhibitor is pretty much not happening for NAION. Currently, the Quark Pharmaceutical study is the big event that's going on with NAION treatment. It's a synthetic siRNA structure. It targets caspase. It's an anti-apoptotic drug, presumably a neuroprotective effect by injecting intravitreally. So it has had some effect in animal axotomy and crush models, actually not ischemic models, but it's been relatively safe. And the thought was that there's potential benefit there. As almost every neuroprotective agent, if you look at these, it looked like it's going to be a benefit, and then we haven't got a proof yet. So this is in progress now. This is a phase 2/3 clinical trial, double-masked, randomized, sham-controlled injection. The first part of this is completed. It is now going on to a longer study, probably another year or two, to see whether there's benefit there. We don't have data on whether it's effective at this point. So what about the fellow eye? I said earlier that all the patients want to know, doc, what's going to happen with my other eye? So the risk of fellow eye involvement has been estimated up to 40% or so, and it depends on sort of how long you follow the patients as to giving an idea what's the chance that other eye is going to be involved. But the two major studies recently looking at this both came up with about the same thing. So somewhere around 15% at 5 years are going to develop fellow eye involvement at that point. That's kind of the figure we tell our patients. And I usually emphasize that that's 85% are not going to have it in 5 years. It's kind of more reassuring to give them the data that way. There's an exception to this, and this is from data from Emory in 2007 and from a study that we did at UCLA in 2013, looking at patients, and I'm going to show you some more data about this later, under the age of 50 who developed NAION. So it does happen in patients under the age of 50, and they develop fellow eye involvement sooner and more frequently. So the fellow eye involvement rate in the Emory study at about 12 months was 35%. And in our study, even at 6 months, it was almost 40%. So whatever's making them get NAION earlier is also making them get the fellow eye earlier as well. So do you use aspirin to prevent the development of NAION in the fellow eye? How's my time here? How much more time do I have?
Let's see. 20 minutes.
About 20 minutes? Okay, good. So there have been studies, and there were studies back in the 90s, thinking about whether you could use aspirin to prophylax and looking at the fellow eye involvement risk and retrospectively looking back at patients who were on aspirin. And they could not really identify a significant enough difference between the patients that were on aspirin and the patients that weren't on the aspirin with respect to the development of NAION in the other eye. So they couldn't identify that it was beneficial, and the numbers were so close that you couldn't really get a prospective clinical trial going. It would have required a huge number of patients, and it just wasn't practical to do. But are NAION patients at increased risk for vascular events? There is some controversial data about this too, but there is some evidence that if you had NAION, you're at risk for myocardial infarction, stroke, early death. There's some studies kind of both way on that, but it makes an argument that if you can do something about it, maybe, unless there's a direct contraindication, you should give them aspirin. And if you look at the Physicians' Health Study, which was from the late 80s and early 90s in the US, looking at healthy physicians and evaluating whether the use of low-dose aspirin reduced their risk of later cardiovascular events, not NAION, but others, it showed a benefit. The problem is there were issues with this, whether the risk of bleeding was worth the risk of reducing the cardiovascular events and so forth. But there is an argument for using low-dose aspirin to prevent the fellow eye involvement with non-arteritic AION. So how do I manage NAION? Number one, make sure that it's not arteritic. Number two, talk about the risk factors, follow the resolution of the disc edema, provide counsel about the therapies, and consider aspirin prophylaxis. And I usually will recommend it if there's not a contraindication after discussion with the patient's internist. So I want to segue to 10 minutes about this separate topic, just because it's an interesting sort of sidelight about non-arteritic AION. So a few years ago, we started looking at this, again, these patients who are under the age of 50. You know, you think about NAION as a disease of the elderly, average age of 60 again, and with risk factors. So I wanted to find out in this whether patients under the age of 50 were different from those that were over the age of 50. Was the risk factor profile different? Were the clinical features different? Was the course different? And is a spectrum of ischemia that includes ischemic optic neuropathy, but also some milder forms, and I'll show you the milder forms and how that might fit in with this. So we found what I showed you earlier. Number one, out of the 850 cases or so that we looked at, about 13% of mine were under the age of 50. That's a biased sample. I was referred to a lot of these because I was asking for it, but still not rare, a significant percentage. So it's not only a disease of patients over the age of 50. The Emory study was also about this percentage of patients, and actually a little higher. So you do see it. The fellow eye involvement rate, I told you, significantly higher for the young. Patients under the age of 50, the fluorescein looks the same. So they've got a swollen nerve, they got poor filling of the nerve with relatively intact filling, choroid, etc., retinal artery. The vessels aren't gone there in these cases where you've got that delay. They're still there. The disc leaks later on, It's just that there's a very delayed progress of the fluorescein through the circulation. So they look the same. So I want to talk about two subcategories as I close this part. One is the so-called diabetic papillopathy. So it's a confusing topic. It originated, this is when in the early 70s, when Dr. Lebeau and company looked at 3 cases of diabetes. These are all juvenile onset diabetics, type 1 diabetics, who developed disc swelling. But they didn't really develop visual field loss. They didn't have a significant dysfunction of the optic nerve. They just developed disc edema, and they were evaluated for other causes and did not find anything else. And over time, the disc edema gradually went away, and it didn't leave much in the way of atrophy of the nerve. Some of them might have had a little bit, but relatively, they got this swelling, and it just went away, but it took a long time. There was a flurry of interest in this around 1980. 3 major papers came out looking at the same disorder and trying to sort of classify it a little bit better. And they all sort of had the same situation, disc edema lasting up to a year. And there were various proposals for why this might be. Was it a metabolic problem of the disc due to diabetes? Was it a microcirculatory abnormality just of the disc surface? Or was it toxic, related to the hyperglycemia, related to those? But it had the same clinical course. And then in '95, a larger study came out of Wills. This is about 20 cases now, indicating that a similar kind of thing, long-lasting disc edema without a lot of visual loss. So if you wanted to define diabetic papillopathy, here's the way I would define it now. Acute onset, disc edema, either unilateral or bilateral, in a diabetic. A lot of them have a prominent optic disc vascular dilation. So in our series, about half of them did this. So you look at this disc and it's just got this carpet of superficial capillary dilation, more than you typically expect in any other cause of edema, really. Very dramatic, and about half of them. Not all of them have that. This patient had this field, so a large blind spot, but really nothing else. So if it was an ischemic optic neuropathy, you'd think terrible field at that point. And gradual resolution again. So it's an acute onset of disc edema in a diabetic with possibly this vascular dilation, no significant visual loss, field loss, and gradual resolution, much longer than you would expect for ischemic optic neuropathy. Those are the theories that I told you about. So one thing I learned from Dr. Hayridge is his discussion of optic disc ischemia, and that disc ischemia is not an all or none phenomenon. There's infarct, irreversible damage of the nerve from ischemia, reversible dysfunction, which I think diabetic papillopathy is, and optic nerve swelling, ischemic swelling without dysfunction. And I'm going to show you a little bit of data that supports that now. So diabetic papillopathy looks different from AION. AION usually unilateral, whereas the diabetic papillopathy may be bilateral. AION has a relative afferent defect, and field loss in the disc edema goes away faster, becomes atrophic, whereas diabetic papillopathy, there may be a little atrophy at the end of it, but not a lot. It's similar to AION in that most diabetic papillopathy has a crowded nerve. That first slide that I showed you about ischemic optic neuropathy had a dramatic telangiectatic surface of it. This looks similar to that. So there's that slide, there's this slide, looks kind of similar. But the most important thing to me and the most interesting thing that I found is that the fluorescein looks like NAION. So I'll show you that in a second, but these are our cases with the similar data that I showed you about. There's that dilated superficial capillary net in over half. Some of them don't have that, and you have to kind of differentiate that from neovascularization, which instead of having a radial papillary net is kind of random and a tangle of vessels on there. So here's what fluorescein looks like. In diabetic papillopathy, it looks like ischemia. So this is kind of off to the side here, but there's very poor filling in the face of normal choroid, normal central retinal artery, very poor filling of the disc. And sort of even later on, very poor filling of that related to the other kinds of disc edema that might show up. Another one, this is without that superficial dilation of the capillaries, but very poor filling of the disc in the face of the rest of this filling well. So it looks like ischemia looks like. Here's a reversible case of diabetic papillopathy. So really dramatic disc half of the disc dilated with capillary dilation, some flame hemorrhages next to it, an inferior altitudinal field defect, not altitudinal, but inferior defect that went along with it. 2 months later, the field defect was gone. This part on the disc was gone. More diabetic retinopathy had developed, but the disc wasn't atrophic. So it looked like a reversible ischemic sort of situation there. And finally, again from Dr. Harry, this discussion of pre-NAION disc edema. So he noted this, incidentally, in some patients with contralateral NAION. He was evaluating them for ischemic optic neuropathy in one eye, looked at the other eye, and found that it was swollen without vision loss. So about half of those in his small series went on to develop ischemic optic neuropathy. The other half, the disc edema resolved without developing an infarct, without developing significant field loss. He didn't do fluorescein angiography in that small series, but we had the opportunity to see one of those. This was given to me by Lynn Gordon, actually, at UCLA. 52-year-old guy who had had ischemic optic neuropathy in the right eye previously. So he had an atrophic nerve in the right eye. He came in with 2 weeks of photopsia in the left eye. And he had a swollen optic disc in the left eye, and a normal field. And the fluorescein looked like those ischemic events. A little bit of central retinal artery filling on this part of the disc, very poor filling on the rest of the disc. It looked ischemic with filling delay, but the field's normal. The disc had edema in it, but no visual loss at that point. 2 weeks later, he developed NAION with this altitudinal loss. The edema kind of eventually resolved as it might. So the suggestion is that was one of those of Harry's cases that had disc edema, ischemic edema, before they lost vision, and this one actually went on to overt infarction of the nerve. So I think there's a spectrum of disc edema, of ischemic disc edema. There's ischemia with severe irreversible loss. There's ischemia with less severe, predominantly irreversible loss, the usual. There's some that's reversible, and there's some that's ischemia without loss that eventually either recovers or goes on to develop NAION. They all look like they have poor perfusion on fluorescein angiography. So, not rare, high fellow eye involvement rate, and this spectrum exists. So I'll stop there, and if you want to ask any questions about non-arteritic AION, please let's go ahead before talk number 2. Yes?
Is there post-cataract surgery and non-arteritic disc? Is there anything?
It's been reported. There are epidemiologic reports. I don't know if everybody heard that, but is there post-cataract non-arteritic AION? There are epidemiologic studies that indicate that it's more common. There are some reports that indicate that NAION does develop in certain cases immediately following the surgery. The cause of it, I'm not clear. There are some suggestions that it might be from high pressure. I'm kind of not convinced of that, but I do feel like these patients with fragile, sort of hardened circulation in the disc, you open the eye, you change all the gradients and all the pressures within the eye, and they can't auto-regulate it. They infarct it. But it's not very common, for sure. Yes?
Is glaucoma under high pressure, uncontrolled glaucoma related to NAION?
Not that I know of. There are theories about glaucoma, the vascular theories that suggest that there's a vasculopathy that is related to it, but uncontrolled glaucoma, for the most part, I don't think it's the same disorder as this.
Okay, we'll
They
take
break.
a break until 4 o'clock.
Okay.